I just want to start with a little bit of history. And you see here the front page of a newspaper published on April 13th, 1945. And the doctor of the president at that time, Franklin D. Roosevelt, his doctor said, you know, it came out of clear sky, and he meant the cerebral hemorrhage of the president, which he died of. And if you look at a picture taken a few weeks earlier, you see these three presidents. Churchill, here he looks quite satisfied, as well as Stalin. Stalin had, in his view, done a good job. He moved the border in Europe to the west, so he was quite satisfied. But look at this man in the middle, that's Franklin D. Roosevelt. He looks not very healthy, and he was still smoking cigarettes, as you see here. That was on Yalta, where the peace talks have been taken place. Looking at the blood pressure values, no wonder why he looks like that. You see here the blood pressure values taken by the doctor of Franklin D. Roosevelt, and the recording started in the 30s, where Franklin D. Roosevelt still had a normal blood pressure of 130 over 70 or so. And you see this blood pressure started to rise, and if you look at the D-Day, when the United States entered the Second World War, you see that his blood pressure rise to values of about 240 over 120. And at the peace talks in Yalta, you see his blood pressure was around 230 over 130, and shortly before he died, his diastolic blood pressure was around 190, and they couldn't measure systolic blood pressure because the devices only were able to measure blood pressure values to values of 350. Our devices today are not measuring as high as at this time. So no wonder why this president died of a cerebral hemorrhage. We are now much more informed about the process of atherosclerosis and the risk factors, and there are many epidemiological studies which have demonstrated that the classical risk factors such as smoking, high cholesterol, hypertension and diabetes lead to atherosclerosis or left ventricular hypertrophy, and atherosclerosis, depending on the vascular bed affected, leads to different diseases such as peripheral artery disease, stroke, coronary artery disease. And this one is importantly determining prognosis in our patients. After a myocardial infarction, for instance, there is worsening of prognosis due to early arrhythmias, and later on due to remodeling and the occurrence of heart failure. So now it's clear we have to treat these risk factors early to avoid these atherosclerotic complications. And in the case of hypertension, we have a rich armamentarium of drugs to lower blood pressure. At the time of President Roosevelt, only very few drugs were available, and these drugs were not very efficient in lowering blood pressure, but had a lot of side effects. In our days, however, we have calcium channel blockers, ACE inhibitors, as well as ARBs, drugs which are well tolerated and are able to lower blood pressure substantially. And there is no doubt that blood pressure lowering reduces cardiovascular morbidity and mortality. That's a meta-analysis of about 1 million patients included into randomized trials. And you see here for systolic blood pressure, there is a clear relation between systolic blood pressure and the risk of fatal stroke. And this is true for all the different age groups, younger patients as well as very old patients between 80 and 90. And blood pressure reduction of 20 millimeters mercury systolic results in a reduction of fatal stroke between 33 and 62%. And similar figures are also true for a reduction of diastolic blood pressure of 10 millimeters of mercury. And if you look at coronary artery disease mortality, these pictures look the same. So it's worthwhile to reduce high blood pressure in order to reduce cardiovascular morbidity and mortality. And if you look at overall daily practice data, and these data have been obtained in the Framingham study looking at cardiovascular and total mortality, you can see that over a time period of 10 years, total mortality was reduced about 25% in men as well as in women, as you can see here, and cardiovascular mortality is reduced about 50%. So there is a dramatic reduction in cardiovascular and total mortality using antihypertensive drugs. We are now in the situation that we can stratify our patients according to their overall risk, and our guidelines tell us to do so. You see here, for instance, the European guidelines. They say that according to blood pressure values and other risk factors, as well as target organ damage or the occurrence of cardiovascular disease, your treatment is different. Let's take a patient with a blood pressure of 145/95. He is at low added risk if he has no other risk factors. However, a patient with a blood pressure of 130 systolic with after a myocardial infarction, he is at a very high risk. So that means in this patient we have to start drug treatment to reduce his overall risk. There are other measures which also have to be implemented, and I really stress you to also focus on that. We have to urge the patient to stop smoking, to not drink alcohol because alcohol increases blood pressure. The diet is also very important. Salt should be reduced, and there should be a lot of fruits and vegetables in the diet. We recommend whole grain and high fiber foods and food reduced in saturated and total fat. But this is not very easy to do it in a daily life. And there is a statement of an American comedian who once said, "I've made a diet and abstained from fast food and alcohol, and in 2 weeks I lost 14 days. So that's what we face every day. We recommend a diet and patients are not following it. Another very important factor is physical activity. I tell the people to go by foot, to use the stairs instead of the elevator. And if a patient does not want to move, I recommend him to buy a dog, because he has to go outside at least twice a day when he has a dog. But it's quite important to choose the right dog. And if you look at this old lady, her dog is a size too big. We have several drugs which are able to reduce blood pressure. The European guidelines still recommend these 6 classes of drugs as first-line therapies: diuretics, beta blockers, alpha blockers, ACE inhibitors, calcium channel blockers, as well as ARBs. I think the situation of scientific data has changed, and I expect to see soon some changes in the European guidelines too. If you look, for instance, at the data put together by Lars Lindholm from Sweden, looking at the effects of all beta blocker trials in hypertension, we have to say that in most of these studies, atenolol was used as a beta blocker. And if you look the risk of stroke, comparing the beta blocker therapy with the other antihypertensive, you see that in those patients treated with a beta blocker, the risk for stroke was significantly higher than for those patients treated with other antihypertensive. Looking at data for myocardial infarction, there was, however, no difference. But these data signify that beta blockers may not be as useful as other hypertensives in reducing stroke. This led to the change of the guidelines in the UK. The British Hypertension Society said that young people at the age of 55 or younger should preferentially be treated as a first-line drug with an inhibitor of the renin-angiotensin system, an ACE inhibitor, or an angiotensin receptor antagonist. In older people, however, or in people with black skin color, in whom we know that the renin-angiotensin system is not activated, they mostly have a low renin hypertension. In those patients, a calcium channel blocker or a diuretic is the preferred first-line drug. If step 1 does not work, these two groups should be combined. A calcium channel blocker or a diuretic with an inhibitor of the renin-angiotensin system. And the third step would be to combine all these three classes. Beta blockers are at the end of treatment. If everything fails, then you may use a beta blocker or another diuretic or a centrally acting sympatholytic. Let's now look at the evidence for calcium channel blockers in clinical trials. There are trials comparing calcium channel blockers with placebo. One of the most important one is the SYSTOR trial. Some years back, patients with isolated systolic hypertension, that means older patients, were either treated with nitrendipine or placebo. And you see here the blood pressure. They started with a blood pressure of 174/86. And in the placebo group, there was also a blood pressure reduction of 13/2 millimeters of mercury, but in the nitrendipine group, blood pressure was reduced 23/7 millimeters of mercury. And there was a dramatic reduction in fatal and non-fatal stroke, and the reduction in myocardial infarction was not significant due to the fact that the trial was stopped early because the dramatic effect they saw concerning cerebrovascular accidents. So I think also older people with systolic hypertension, they should be treated, and we have further evidence from the HIVET trial also looking at the effects of antihypertensive therapy in the very old. Looking at the overall picture of all calcium channel blocker trials performed against placebo, you see a dramatic reduction of about 40% concerning stroke. Major cardiovascular events are reduced about 30%, and cardiovascular death was reduced around also 30%. So calcium channel blockers are really effective in the treatment of hypertension. They reduce cardiovascular morbidity and mortality. Another factor which is quite important in our patients is persistence, or we call it compliance. And if you look at compliance data over a longer period of time, Thomas Unger has done that over 4 years. You see that compliance in thiazide diuretics, after 1 year, about 21% of the patients are on the drug. After 4 years, only 16% are on the drugs. For beta blockers, it looks a little bit better, about 45% after 1 year, and about 1/3 of the patients after 3 years. For calcium channel blockers, ACE inhibitors, and ARBs, the data are much better. So the drugs are better tolerated, and that's the reason why people stay on the drug for a longer period of time. You have to keep in mind that drugs do not work in patients who don't take them. So that's important in our daily practice. Let's now look at the different forms of nifedipine. You know, nifedipine is on the market in Pakistan for about 30 years or so, and there are dramatic changes in formulation of nifedipine. We now have a high-tech formulation of nifedipine, the so-called GITS, gastrointestinal therapeutic system, which is able to reduce blood pressure substantially and has a particular kinetic. It's a high-tech pill, as I mentioned. There is laser-engineered technology involved. With a laser, a small hole is being drilled into this capsule, and this capsule is covered by a semi-permeable membrane and filled with drug, as you can see here in red, and a polymeric push compartment. And this polymeric push compartment can take up liquid water, and taking up water, it expands and pushes out the drug in a constant rate, as you can see here. This is getting bigger and pushes out nifedipine, and nifedipine pushed out is taken up by the gastrointestinal system, reaching the blood and acting as a hypertensive. And looking at the plasma concentration of nifedipine. After nifedipine capsules we used to treat our patients with about 25-30 years ago, you see that there is a rapid increase in plasma concentration, and after a few minutes there also already decrease in plasma concentration. So you have a rapid drop in blood pressure, and the effect of the drug disappears within a few hours. Later on, we had the nifedipine retard, 20 milligram. You see the rise is less dramatic, but there is already a reduction in concentration of about after about 8 hours. So you have to take this drug at least 2 or 3 times a day, and there are changes in plasma concentration despite the fact that you have a retard formulation. But this nifedipine GITS formulation, you see there is a slow but steady rise during the first 4 hours, and then the plasma concentration remains stable over 24 hours, and there at this point you would give another pill, and this will continue. So you have a constant and stable concentration of the drug in the blood. Looking at the response of the cardiovascular system, first heart rate, and heart rate increase means activation of the sympathetic nervous system. You see after nifedipine capsule there is a dramatic increase in heart rate of about 30 or 40 beats per minute. If you look at the nifedipine retard, still there is a substantial increase in heart rate, but after nifedipine GITS, heart rate remains completely stable. So that means there is no activation. And indeed, if you measure plasma concentration of noradrenaline, which is a marker for the activation of the sympathetic nervous system, you see that there is increase in heart rate after retard nifedipine, but nifedipine GITS does not produce any rise in noradrenaline. That means no activation of the sympathetic nervous system. Looking at blood pressure, in which we are most interested in, there is a rapid drop in blood pressure after the nifedipine capsules we used to use in hypertensive emergencies. But now we left this treatment concept because we saw, due to the rapid drop in blood pressure, we saw some strokes in these patients. So we don't use it anymore. Nifedipine retard, there you see a drop in blood pressure of about 25 millimeters of mercury, but after 12 hours your blood pressure is lowered only about 10 millimeters of mercury. However, there is a parallel reduction in blood pressure after administration of nifedipine GITS, and this at the end results in an excellent trough-to-peak ratio. And this trough-to-peak ratio is quite important also for cardiovascular morbidity and mortality, as we learned during the last 20 years or so. So what we have seen an evolution of nifedipine. It started with the GITS formulation, and we were happy at that time to have a calcium channel blocker, another antihypertensive to lower blood pressure besides diuretics and beta blockers. So we were happy to have another drug class. But then afterwards we had the nifedipine retard, which you have to administer at least 2 times a day. But in our days we have the ideal pharmacodynamically active nifedipine GITS, which leads to a blood pressure reduction over 24 hours with an excellent trough to peak ratio, and I think it's the most suitable drug in our patients. And also you have to keep in mind that calcium channel blockers, and in particular dihydropyridines, are ideal drugs for everybody. Why? Calcium channel, in patients treated with the calcium channel blockers, you don't have to check anything. You don't just check blood pressure. You don't have to check kidney function. You have to do it in a patient treated with an ACE inhibitor or an angiotensin receptor antagonist. And you don't have to check ECG, whether there is an AV block, as you have to do it with a beta blocker. So a calcium channel blocker, I always tell our physicians in Switzerland, a dihydropyridine calcium channel blocker is a no-brainer. You don't have to think about anything than to give the drug and instruct the patient to take the drug every day and measure the blood pressure. And using these drugs, I'm sure and convinced about clinical data, you reduce cardiovascular morbidity and mortality. That's the 24-hour blood pressure reduction, as you can see here, and this excellent trough to peak ratio with nifedipine GITS. And that's the evolution, the capsules, the retard, and the nifedipine GITS. And we have evolution everywhere and every day. I can remember my parents drove this car, this Volkswagen, in the early 60s, and you know, later on there come more horsepower with the old Porsche, and my boss is now driving a car like that. I can't afford it, but that's the evolution in cars. Let's now look at the evidence of calcium channel blockers against other antihypertensive drugs. One of the trials was the VALUE trial. In high-risk hypertensive patients, patients were randomized to either valsartan, an ARB, or amlodipine calcium channel blocker. There was no difference concerning cardiovascular endpoints, fatal and non-fatal myocardial infarction or stroke. However, blood pressure reduction was better in particular early during the trial. And you can see during the first 6 months the reduction in blood pressure was better with the dihydropyridine calcium channel blocker. You see here systolic blood pressure reduction about 4 or 3 millimeters of mercury better with the calcium channel blockers. And if you look at the cardiovascular morbidity and mortality during this early phase of the trial, there was a benefit for the calcium channel blocker. That means rapid reduction, rapid reach the goal in these hypertensive also translates into reduction in cardiovascular morbidity and mortality. Looking at nifedipine GITS data, nifedipine GITS has been compared to a combination of 2 diuretics, hydrochlorothiazide and amiloride, in the INSIGHT trial. And you see here in these patients with hypertension, they had a blood pressure of 173/99, and this was reduced to 138/82 in both groups. The calcium channel blocker was as effective as 2 diuretics in more than 6,000 patients. Looking at the blood pressure reduction and compare it to other trials, you see that in this trial they have really done a good job. They reduced systolic blood pressure to goal and also diastolic blood pressure, and you see that in many trials this was not the case. looking at the primary endpoint, which was cardiovascular death, myocardial infarction, heart failure, and stroke, there was no difference between the two groups. However, there was a difference in kidney function. Those patients treated with a diuretic, they had a significant deterioration of kidney function, whereas in the nifedipine-treated patients, the kidney function remained stable. Another factor was diabetes, and here you see overall view of different trials comparing calcium channel blockers, ACE inhibitors, and ARBs with diuretics or beta blockers. Beta blockers and diuretics are known to have the possibility to induce impaired glucose tolerance or diabetes. And you see here, compared to ACE inhibitors, calcium channel blockers, and ARBs, beta blockers or diuretics increase the risk of diabetes during the trial. Here you have the data for the INSIGHT study. The occurrence of diabetes was 30% more in the diuretic-treated patients compared to those treated with nifedipine GITs. So there are advantages. But in daily life, you have the same patients as I have in daily life. One drug is often not enough. And you see here different trials and the blood pressure values reached in these trials. You see that in these trials, ASCOT, ALHAD, you name it, at least 2, even 3 or more drugs have been used to reach these blood pressure goals. And if you look at the figures, how many patients have been treated with more than one drug. You see in the ALHAD trial it was 42% in life, comparing a beta blocker with an ARB, and the ARB was better, but the ARB in 90% combined with a diuretic in both groups. Value, you see about 70% were treated with a combination. In ASCOT, about 80%. In HIVET, recently published, about 75% of the patients received at least 2 drugs. And this also led to a changement in our guidelines. Our guidelines say patients with mild elevation of blood pressure, in those patients you may use a single drug, and then you may increase the drug in dosage, or you combine it with, or you switch it to another drug. In patients with a marked elevation of blood pressure, or in those patients in whom blood pressure goal is 130 or below, one drug is not sufficient. And the guidelines say in those patients you should use combination therapy. 2 drugs at a low concentration are better tolerated than 1 drug at a high dosage. And if you look at the combination of dihydropyridine calcium channel blocker in addition to other drugs, you see that the calcium channel blocker reduces blood pressure around 15 to 20 millimeters of mercury systolic, irregardless on which drug the patient is. Let's now discuss a recently published trial, the ACCOMPLISH trial. That's the first trial comparing fixed combination in both arms. A combination of an ACE inhibitor with either a diuretic or an ACE inhibitor with a dihydropyridine calcium channel blockers. And there was benacepril as an ACE inhibitor and amlodipine or hydrochlorothiazide as a diuretic in high-risk patients. And you see here 50% were obese, 60% had a diabetes, 97% were treated previously, 74% were treated already with 2 or more antihypertensives. The age was around 70, and 78% already were on an ARB or an ACE inhibitor. And you see that really the doctors treated these patients adequately. 70% were receiving a lipid-lowering drug, and the mean LDL cholesterol was around 2.6 or 100 milligrams per deciliter. And with all these drugs, only 38% had a blood pressure below 140/90. And here you see blood pressure. Blood pressure was reduced significantly in both groups, and blood pressure reduction was similar. You see here there was a difference. The calcium channel blocker as the partner for the ACE inhibitor was a little bit more effective in reducing systolic blood pressure as well as diastolic blood pressure. And here you see the control rate in both arms. About 80% of the patients were at a blood pressure below 140/90. And about 75% were controlled with one pill, with one combination pill. And the trial was stopped early because there was a difference in the primary endpoint. The primary endpoint, cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, hospitalization for unstable angina, coronary revascularization, and a successful resuscitation, was reduced by 20% in those patients receiving the calcium channel blocker as the partner for the ACE inhibitor compared to those receiving the diuretic. You would tell me, you know, it's obvious because calcium channel blockers reduce angina and therefore they have less unstable angina, less revascularization. But if you look at the endpoints without vascularization, there was still a 21% significant reduction in endpoint. If you only look at the hard endpoints, cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke, there was still a 20% reduction in those patients receiving the calcium channel blocker. And if you look at all-cause mortality, there was a strong trend for a reduction in those patients receiving ACE inhibitor combined with the calcium channel blocker. So, calcium channel blockers as partner for another antihypertensive are beneficial. You have data from the ASCOT trial where the calcium channel blocker was combined with the ACE inhibitor, and from the ACCOMPLISH trial, again, calcium channel blocker with the ACE inhibitor against the diuretic combination. I think, therefore, a calcium channel blocker and an ACE inhibitor should be the first-line combination therapy in a second step for the treatment of essential hypertension. Let's now move on. We know that nifedipine is successful in reducing blood pressure. We use it in daily practice for our symptomatic patients with coronary artery disease having angina pectoris. And there was a big debate in the early 90s, mid-90s about the safety of calcium channel blockers in patients with coronary artery disease. And there were a lot of investigations looking at the effects of calcium channel blockers on atherosclerosis. And I just show you a small movie about the development of atherosclerosis. You see this intima thickening, this lipid core in atherosclerotic plaque. You see here this fibrous cap, and this fibrous cap may break up, and then the blood comes in contact with the lipid core, and what we see at the end is a thrombus and the patient with a myocardial infarction or a stroke. It became clear that this inner layer, these endothelial cells, are crucial for the development of atherosclerosis. And there are several factors which may influence endothelial function: hypertension, dyslipidemia, smoking. All these known risk factors affect endothelial function and promote the process of atherosclerosis. Therefore, many trials have looked at the effects of drug therapy on endothelial function. And there is a substantial number of excellent clinical trials. We have done some of them, and other investigators looking at the effects of nifedipine. And in hypertensives, for instance, Stefano Taddei and we have nicely shown that endothelial function can be normalized with nifedipine, in contrast to a beta blocker or a diuretic, for instance. And as you can see here, the process of atherosclerosis is a process of many, many years. And we should interfere with this process early in atherosclerosis. And one of the trials performed with nifedipine as well as a lipid-lowering drug, cherovistatin, was a large trial in patients with coronary artery disease. We looked at endothelial function in a multi-center trial and the effects of a 6-month nifedipine therapy. And as you can see here, the change in endothelial function, there was a significant improvement of endothelial function in the coronary circulation of patients with coronary artery disease receiving nifedipine GITS. So there is a lot of evidence. And looking at vascular structure, we also have evidence from the ENCORE 2 trial where intravascular ultrasound has shown that nifedipine reduces or even blocks the progression of development of new plaques. Even old trials such as the INTACT study has already shown that nifedipine retard is able to reduce the development of new lesions in patients with coronary artery disease. And endothelial function is of prognostic significance. Here you see data of Andreas Zeyer in Freiburg in Germany. He looked at endothelial function in the coronary circulation in patients with chest pain. And you see here in patients with normal coronary artery disease, when they have normal endothelial function, that means vasodilation, their prognosis is excellent, whereas in those patients with endothelial dysfunction, about 25% of the patients had a cardiovascular event over a period of 10 years. And there is evidence nifedipine GITS retards the progression of atherosclerosis. And a sub-study of the INSIGHT trial looking at intima media thickness at the level of the carotid artery, you see that the diuretic-treated hypertensives show a progression of intima media thickness, whereas those patients treated with nifedipine, there was absolutely no progression, indicating that indeed, besides lowering of blood pressure, nifedipine also has a direct effect on the vessel's wall. Looking at coronary calcification, which is also a surrogate for coronary artery disease. In the INSIGHT trial, again, comparing these hypertensive patients either treated with a combination of the diuretic or nifedipine GITS, you see that in both groups, however, there was a progression of calcification, but there was a more rapid progression concerning calcification in the coronary arteries in those patients treated with a diuretic compared to those treated with nifedipine GITS. So another hint that nifedipine GITS has a direct effect on the coronary arteries. Reduction of blood pressure, improvement of endothelial function, and inhibition of atherosclerosis is nice to have, but we want to see more. We want to see more action. And that's the acronym of a large clinical trial using nifedipine in patients with symptomatic coronary artery disease. And this is the first ever randomized placebo-controlled clinical outcome trial on an anti-anginal drug in patients with symptomatic stable angina pectoris. It's designed to assess the effects of nifedipine GITS on cardiovascular event-free survival. And the patients pre-treatment met the best practice criteria at the time of recruitment. Patients with proven coronary artery disease were randomized either to receive nifedipine GITS 30 to 60 milligrams a day or placebo. More than 7,000 patients were randomized. And here you see the baseline medication. Anti-anginal treatment was present in 99% of the patients. 70% received a lipid-lowering drug. ACE inhibitors were used in 20%, aspirin in 86%, and beta blockers in 80%. You see that nifedipine reduced blood pressure in these patients, significantly systolic as well as diastolic. The primary endpoint was death, myocardial infarction, refractory angina, heart failure, stroke, and peripheral revascularization. There was no difference between the two groups. And the safety endpoint, death, myocardial infarction, and stroke, no difference. And if you look at all-cause mortality, no difference. However, in the secondary endpoint, there was a significant reduction in additional endpoints such as cardiovascular events and procedures such as CABG, PTCA, and coronary angiograms. Looking at the component of the endpoints, you see that there was a 29% reduction in heart failure. The reduction in disabling stroke was 22%, but did not statistical significance. But including also transient ischemic attacks, there was a significant reduction. Angiograms were reduced 18%, CABG 21%. So there was a significant reduction in cardiovascular endpoints. And nifedipine is a safe drug. Let's compare action to other famous trials, such as the HOPE or the Europa trial. You see a similar number of patients have been included, and you see that follow-up was similar in all these trials. Annual mortality rate, however, was significantly higher in the HOPE trial than in the other trials. And why was this? The patients in the HOPE trial were older. They had more peripheral vascular disease. They had more diabetes, 38% compared to around 15% in the other trials. And you see that at this time in 2000, people were not as well treated as later on. Only 28% received a lipid-lowering drug, whereas in the other trials, such as the Europa and the ACTION and the PEACE trial, about 70% received a lipid-lowering drug. Looking at the different endpoints, you see, for instance, no fatal myocardial infarction was reduced in the HOPE trial. In the Europa trial, it was also reduced, but it was not really fair. They changed the definition of myocardial infarction during the trial. So they also included patients with troponin-positive acute coronary syndromes. Look at heart failure hospitalization. This was reduced in Europa as well as in the ACTION trial. Stroke reduced in HOPE, in ACTION, and not in the other trials. Looking at the primary endpoint, however, you see that similar reductions in the different primary endpoints, composite endpoints, were reached in all these three trials. So there is not the question whether ACE inhibitor or calcium channel blocker. I think both drugs have a role in these high-risk patients. Let's look at the subpopulation, which consists more than 50% of these patients in an ACTION trial. That are those patients with a blood pressure above 140/90. And you see here blood pressure reduction in about 4,000 patients who had this hypertensive blood pressure. There was a significant reduction of systolic as well as diastolic blood pressure. And the primary endpoint in this more than 50% of the population of the ACTION trial was significant. The primary endpoint of all-cause mortality, myocardial infarction, refractory angina, heart failure, stroke, and peripheral revascularization was reduced by 13%. And you see here the figures: 38% overt heart failure, 33% debilitating stroke, including also TIA. There was a 28% reduction, 16% reduction in coronary angiograms. And comparing the overall population with the hypertensive subgroup, you see the primary endpoint was significantly reduced in the subgroup, but the other endpoint, there was a similar reduction in the overall population compared to the hypertensive subgroups. A substantial reduction in heart failure and stroke. And I think this is due to the dual mode of action of the calcium channel blocker. It's not only blood pressure reducing heart failure and stroke, but it also has a vasoprotective effect, and this then leads to a reduction in coronary intervention and reduction in refractory angina. And at the end, we see a significant reduction in cardiovascular morbidity and mortality. So I think there is a lot of evidence now that nifedipine is successful in treating our patients at high risk with hypertension as well as with atherosclerosis. We have evidence from the INSIGHT trial in hypertensive patients. We have evidence concerning atherosclerosis and endothelial function from the large multi-center ENCORE trial, and the ACTION trial at the end has shown that it's safe in patients with coronary artery disease, and it reduces cardiovascular morbidity and mortality, and even it reduces heart failure. So in summary, I would like to conclude nifedipine is a safe drug. It lowers blood pressure efficiently, and in patients at high risk or coronary artery disease, nifedipine affects angina symptoms. It reduces angina. Nifedipine improves endothelial function and therefore also influences the process of atherosclerosis. And nifedipine reduces cardiovascular events, in particular in hypertensive patients. Nifedipine has also the potential to slow down the progression of atherosclerosis. I thank you for your attention. Shukran.